My name is Mike Heffler, and I'm currently clinical faculty at the University of Colorado Anschutz Medical Center and a graduate of the Denver Health Emergency Ultrasound Fellowship. Nerve blocks are one of the hottest topics and fastest growing areas in emergency medicine these days. You may be thinking that you'd like to start using some of these in your practice, but want to make sure that you do so safely. And I'd like to provide a primer on how you too can learn to rock the block safely. I have no conflicts of interest to disclose. First, we'll define exactly what is a nerve block. We'll discuss why we should be employing them. We'll highlight some of the important risks to be mindful of. And then we'll discuss how I approach performing a nerve block. In this talk, we'll just scratch the surface of nerve blocks, but I'll provide references on how to learn more about this topic. So first, what is a nerve block? Pain sensing starts with transduction of a painful stimulus into an electrical pain signal by pain receptors in the periphery. This signal is then transmitted along peripheral sensory nerves to the spinal cord. The signal then ascends in the spinal cord and the brainstem, where it's modulated by ascending and descending pain pathways that either amplify or attenuate the signal, and eventually the signal reaches the cortex, where the modulated signal is then perceived as pain, with the physical and emotional effects that confers. The goal of a nerve block is to stop transmission of that pain signal from the periphery so a patient never perceives pain at all. We do this by using sodium channel blockers, which interrupt the saltatory signal transmission. You'll likely recognize many common local anesthetics as sodium channel blockers, including lidocaine, bupivacaine, benzocaine, and of course, cocaine. So, nerve blocks work by using sodium channel blockers to stop pain signal transmission. A nerve block is performed by using a needle to inject local anesthetic, and we can do that in two ways. Directly, where we use ultrasound to guide the needle tip next to a nerve of interest and inject anesthetic around it, and by using a fascial plane technique, where we inject a large volume of anesthetic into a specific fascial plane, allowing the anesthetic to spread over a large area and anesthetize multiple nerves. Importantly, many nerves of clinical importance lie very close to arteries and veins, so using real-time ultrasound guidance is critical to ensure proper location of the needle tip and to avoid intravascular injection or arterial puncture, which can be harmful. So then, why should you perform nerve blocks? We know that any exposure to strong analgesics like opioids confers some risk of dependence and abuse. Using nerve blocks reduces the need for some of these analgesics, which can reduce the longer-term risk of opioid dependence, abuse, and addiction. Additionally, some patient populations with already high tolerance to opioids also benefit from better pain control with nerve blocks, such as patients who use illicit IV opioids or those on chronic opioid therapy for chronic pain syndromes. Reduced opioid and sedative use is even more important in pediatric and geriatric populations, where risks of respiratory depression and delirium can be avoided without sacrificing pain control. A 2020 Cochrane review and meta-analysis of geriatric hip fractures found a significantly lower incidence of delirium with fascial iliaca blocks versus usual care, with the number needed to treat of only 14. And a 2007 randomized controlled trial of children with femur fractures showed better, longer-lasting pain control requiring fewer doses of opioids for those receiving fascial iliaca blocks. Beyond those effects, nerve blocks are very practical in the emergency department and allow one to perform typically painful procedures such as dislocation reduction or wound debridement without resource-intensive procedural sedation. Use nerve blocks to save your resources. Ultrasound-guided nerve blocks are also supported and encouraged by our clinical and academic societies. The American College of Surgery Committee on Trauma recommends nerve blocks in the routine care of trauma patients, and ACEP endorses ultrasound-guided nerve blocks as a core component of multimodal analgesia. These are well-studied, accepted techniques that have long been used by acute pain specialists in the inpatient setting. When performed with the proper training and safety procedures, nerve blocks are safe, effective, and they are the standard of care. But every procedure has risks, so what are the risks with nerve blocks? Some of the most important include local anesthetic systemic toxicity, or LAST, infection, bleeding, direct nerve injury, masking of a nerve injury, and masking of compartment syndrome. We'll focus on these three, which represent the bulk of the risk in the emergency department. Local anesthetic systemic toxicity, or LAST, results from multiple mechanisms, with sodium channel blockade as the primary mechanism. The risk is highest when a nerve block infiltration dose is accidentally given intravascularly, but it can also occur if too high a dose is given and is slowly absorbed into the serum. Generally, LAST proceeds from nonspecific symptoms such as perioral paresthesias, anxiety and agitation, to CNS excitation with seizures and tachycardia and hypertension, to altered mental status, coma, and ultimately to dysrhythmias and cardiac arrest. LAST can also skip steps and can initially present with severe symptoms as well. Rapid recognition and early treatment of severe LAST is critical. If during or shortly after an injection a patient has signs or symptoms of LAST, develops new tachycardia, altered mental status, or has a seizure, stop the injection immediately and apply at 100% oxygen by face mask. With these severe symptoms, start a 20% lipid emulsion or intralipid by giving a bolus of about 100 mL up to 3 times max. An infusion can also be started if the patient fails to respond to the initial boluses. Involve your local poison center or toxicology team early for these cases. For more detailed information on LAST management, you can see resources at lipidrescue.org, which is a great resource for just-in-time management of local anesthetic systemic toxicity. LAST most commonly occurs when anesthetic is injected intravascularly instead of into soft tissue, or when a dose calculation error results in too high a dose being injected. LAST can also occur when the correct dose is injected in the correct location, so having a high index of suspicion in the post-block period is key. Also recognize that certain patient populations, such as elderly patients, those with low BMIs, pediatric, and pregnant patients, are at particular risk for LAST, so a dose reduction for these patients adds an extra margin of safety. So be sure to select your patient thoughtfully when deciding to perform a block, and be aware of any potential elevated LAST risk. Carefully calculate your dose using a dose calculator, which we'll talk about in a bit. Make sure to always use ultrasound for your nerve blocks to ensure that the needle is in the correct location and that anesthetic spreads in your intended location. Aspirate before and frequently during injection to ensure that your needle has not migrated into a blood vessel. And monitor your patients for at least 1 hour after blocking. While this 1 hour period of monitoring will identify most cases of LAST, be aware that LAST can present in a delayed fashion hours afterward, so communication with inpatient teams for admitted patients and good return precautions for discharged patients are key. Direct injury to a target nerve is uncommon when using ultrasound guidance effectively, and usually results from laceration of the nerve by the needle itself, or injection of the anesthetic directly into the nerve fascicles, which causes elevated pressure and a local compartment syndrome of the nerve. This clip is an example of an intraneural injection which occurred when the visualization of the needle tip was briefly lost. Thankfully, many of these direct nerve injuries are minor, and many times patients recover quickly and fully, as in this case. Nerve injury is best avoided by always maintaining a full and clear view of the entire needle length during the entire procedure, starting with a gentle test injection to confirm that the anesthetic spreads around but not within the nerve, stopping immediately if the patient develops any paresthesias or numbness during the injection, and by using a blunt-tipped needle like a block-specific needle or Quincke-tip spinal needle. These blunt-tipped needles have a lower chance of causing a nerve injury as compared to a standard hypodermic needle. The hallmark of compartment syndrome is severe pain, which precedes paresthesias, paralysis, or pulselessness. Theoretically, a nerve block could mask this pain and could delay recognition of compartment syndrome, and so injuries at particularly high risk of compartment syndrome, or any injury with a suspected developing compartment syndrome, should not have a block performed. This theory of masked compartment syndrome by a peripheral nerve block alone is controversial and may not be borne out by the evidence, but the consequences of a missed case of compartment syndrome could be catastrophic to the patient. So for the time being, avoid blocking any high-risk injury for compartment syndrome. These include both bone forearm fractures, tibial plateau or pylon fractures, high mechanism injuries, or any injury with a large amount of soft tissue injury. In general, blocks should be held if a patient has an allergy to the proposed local anesthetic, an injury with a high risk or suspicion for a nerve injury, an injury with a high risk or suspicion for compartment syndrome, or patients who are unable to provide consent on their own and do not have a medical proxy present. So, now let's get into the nuts and bolts of how to actually perform nerve blocks. A good general mnemonic for thinking through and preparing for a nerve block is MD Slim. First, choose your medication, calculate your dose, set up your supplies, locate the nerve or fascial plane of interest, perform the injection, and then monitor your patient for signs or symptoms of local anesthetic systemic toxicity. Start by choosing your medication. Generally, we have short-acting and long-acting agents. Lidocaine lasts for about 1 to 2 hours, and this can be prolonged with epinephrine to about 2 to 3 hours, whereas bupivacaine will last on the order of 12 hours. If you have access to it, ropivacaine is preferred over bupivacaine as it has less risk of last and cardiotoxicity, and it lasts for about the same duration. The effects can be further prolonged by adding dexamethasone to the anesthetic solution prior to injection. A 2017 Cochrane review and meta-analysis found that the addition of perineural dexamethasone prolonged anesthesia by about 6.7 hours compared to placebo. The optimal dose is not clear, but it's likely in the range of 4 mg to 10 mg. Like any steroid, using perineural dexamethasone does have a risk of hyperglycemia, so I would recommend using a low dose in patients with diabetes who are at risk for hyperglycemia. Now that you've chosen your medication, decide how much volume you need. For direct nerve blocks where you can see the nerve of interest, the goal is just to surround the nerve with anesthetic. This usually requires 10 to 15 mLs depending on the size of the nerve. This technique is used for brachial plexus blocks, forearm blocks, and popliteal sciatic blocks. These lower volumes rarely approach toxic doses of anesthetic in adult weight patients. In contrast, fascial plane blocks require high volumes of anesthetic to dissect a specific fascial plane and spread anesthetic along the plane. This includes blocks such as the fascia iliaca, serratus anterior, and erector spinae blocks. These high volumes frequently approach toxic doses of anesthetic, so careful dose calculation and planning are essential. You can manually calculate the maximum dose and volume by multiplying the concentration of your anesthetic in percent by 10 to give the concentration in milligrams per ml. You can then use a complicated chart like this to find the maximum safe dose, multiply by the patient's weight, and then convert that dose to volume for your specific concentration of anesthetic. Unsurprisingly, this is complicated, cognitively taxing, and extremely error-prone, and this is the source of most errors when performing nerve blocks. Instead, I recommend using a dose calculation app like SafeLocal, which prompts you for the anesthetic and the concentration, the patient's weight and medical comorbidities, and provides you with a maximum volume of anesthetic. I would further reduce this maximum by about 20% for an extra margin of safety. Using an app like this for dose calculation is quick, reduces your cognitive burden, and reduces the chance for calculation error. With your medication chosen and dose calculated, now gather your supplies. There are commercially available block kits like these, which contain a sterile transducer cover, sterile prep, and syringes and needles for drawing up your meds. But if you're not lucky enough to have these prefabricated kits available at your shop, the bare minimum that you need is your medication, your needle and syringe, a sterile prep, sterile gloves, and for fascial plane blocks, I do recommend at least using extra J-loop tubing or IV tubing and handing the syringe to an assistant so you, the operator, can focus on handling your transducer and needle while the assistant aspirates and injects when it's appropriate. While these procedures are not strictly sterile, we should strive to perform them in as sterile a way as possible, so I do encourage using sterile gloves for these and using a single-use sterile ultrasound probe cover as well. If you don't have easy access to probe covers, you can use a spare set of sterile gloves instead. Hold the extra glove and ask an assistant to slide your ultrasound transducer with gel into the cuff to quickly make a sterile probe cover. For any fascial plane block, or when giving more than 10 mL of anesthetic, make sure to place the patient on the cardiorespiratory monitor, or at least continuous pulse oximetry. Because the earliest signs of LAST include vital sign changes, continuous monitoring helps to pick this up early. This is especially important when using bupivacaine or when doing any large volume plane block, as these are the highest risk times for local anesthetic systemic toxicity. With your supplies and your patient ready, now set up your ultrasound. Most nerve blocks are best done with a linear probe, as nerves tend to be superficial and many have vascular and soft tissue landmarks, which are best seen with a high-frequency linear probe. Importantly, set up the ultrasound across from you so that your ultrasound hand, your needle hand, and the ultrasound screen are all directly in line. This reduces your cognitive load and is easier for your hand-eye coordination. With everything ready, now locate the nerve or the fascial plane of interest with ultrasound. This is the core content of ultrasound-guided nerve blocks, and where many providers need to learn and study in order to feel confident. Having a mental anchor image of ultrasound landmarks is critical. Reading and learning about nerve blocks beforehand helps to build your foundation of knowledge, but don't be afraid to use just-in-time resources just prior to performing blocks. I do this all the time. The New York School of Regional Anesthesia, or NYSORA, is a great, comprehensive resource with a wealth of information on nerve blocks, discussions of the gross anatomy, sonum anatomy, and tips and tricks for performing a wide variety of nerve blocks. It's an excellent reference website, but can be hard to use on shift due to the depth of information. Highland Hospital in Oakland has a great EM ultrasound website with a ton of ultrasound-guided nerve block info tailored to the emergency clinician. This is great foundational knowledge, but is also a bit in-depth and hard to use on shift. Duke's Regional Anesthesia Program has a great YouTube channel with a series of in-depth videos on a wide variety of block techniques and is a great resource to review prior to shift. To refresh your memory on shift just before performing a nerve block, you can also use these just-in-time resources. Full disclosure, I did help create both of these, but I do think they are especially useful on shift for quick refreshers. The POCUS Atlas's Nerve Block Atlas has annotated guides of landmarks and sonum anatomy and many example clips of various nerve blocks. The Nerve Block app is helpful to suggest an appropriate nerve block based on a given injury location and reviews block indications and expected areas of anesthesia. Once you have your supply set up and have located your target, perform the block. In-plane guidance is preferred for most blocks because this allows you to visualize the entire length of the needle for the entire duration of the procedure. You want to gently and deliberately guide your needle tip to the proper location, aspirate frequently to ensure you get no blood return, and then use gentle, small injections of anesthetic to ensure that it spreads around your nerve of interest or within your fascial plane of interest. In-plane guidance does require a lot of hand-eye coordination, but seeing the entire needle prevents accidental intravascular injection, nerve injury, arterial puncture, and prevents pneumothorax during thoracic blocks. One issue that complicates in-plane guidance is the angle of incidence. Since ultrasound imaging relies on echoes returned from an object, the more perpendicular a linear object is to the ultrasound beam, the brighter it will appear. There are a variety of techniques that can help improve needle visualization when using in-plane guidance. One strategy is to heel the probe by rocking it to angle the ultrasound beam more perpendicular to the needle. As you can see in this clip, this is tough to do without lifting off of the skin and losing contact. An easier technique is to use as shallow a needle angle as possible. Do this by inserting your needle further away from the transducer in order to take the shallowest practical angle. For deeper blocks like the erector spinae or transgluteal sciatic block, this is not always feasible, but is easier for more superficial blocks like the fascia iliaca or forearm blocks. Another strategy is to make the machine do the work for you by using beam steering. Most modern machines have a mechanism to alter the propagation of the ultrasound beam to be slightly off the vertical axis. Even just a 10 to 20 degree tilt can be huge for improving your needle visibility. Each manufacturer has a different name for this mode, such as iNeedle, NeedleViz, etc., so play around with your machine to find out what this setting is called. You can also reach out to your manufacturer's representative to figure out what this setting might be called on your machine. Once you complete the injection, monitor your patient for a period of time to assess the efficacy and to look for signs of last. There are no clear guidelines on a minimum observation time, but 30 minutes is probably sufficient for most blocks. For larger volume fascial plane blocks, 60 minutes is advisable. So, to perform an effective nerve block, be MD slim. Choose your medication, calculate your dose, set up your supplies, locate the target nerve or fascial plane, perform the injection, and then monitor your patient for adverse events. There is so much more to learn about the world of ultrasound-guided nerve blocks, and I hope that this lecture inspires you to explore and incorporate these techniques into your routine practice. Thanks for watching, and please reach out with any questions.